Well, here we're looking at some classic diabetic foot callus. You can see the hard patches of keratinized skin. And this has occurred in several places over the surface of this patient's foot. Here we see some under the toenail, and the suspicion has to be that there's a pressure area and an area of infection underneath this area of hard callus. Here we see some hard callus which has been peeled off, and this can be now cut off, and this wound can be allowed to heal by secondary intention. But you've got to get rid of the hard callus on top first to open up the wound, so you can then get in to heal it by secondary intention. Well, here we see a particularly severe case of peripheral vascular disease. The dressing covers an injury which wouldn't heal due to ischemia. You can clearly see the black necrotic tissue on the toes. The patient's already lost the other limb due to peripheral vascular disease, requiring amputation. So we see the black necrotic areas where basically there's no blood getting to at all, and the areas have simply died. This toe is essentially dead tissue now. It's gangrenous. Essentially the toe is decomposing. Significant discoloration of the foot. This patient was actually systemically confused. Bacteria from the decomposing area was getting into the systemic circulation, giving rise to the risk of a systemic blood poisoning. A little bit of gauze there to try and stop the toes from rubbing together, but didn't make any difference really. This limb actually required amputation shortly after these shots. No pulse palpable there on the foot. I couldn't feel anything at all actually. Posterior tibial again, I couldn't feel anything at all. This was the end stage of a long-term disease process. It wasn't acute, it was a long-term ongoing chronic condition that deteriorated to this level of severity in a diabetic patient. We can see here that part of the great toe has already been removed, and that the second toe is showing significant discoloration and infection. And this infection has spread to an area of cellulitis affecting the foot, which has been marked off with the felt pen. This will allow us to detect if there's any spread of the infection. When we look at the plantar surface of the foot, we see a lesion underneath the second toe. The patient was largely unaware of this because he has sensory peripheral neuropathy. And this lesion developed as a result of pressure, resulting in an area of necrosis. It became rapidly infected, and the infection unfortunately tracked to the bone, leading to osteomyelitis. This set up chronic infection within the toe, and as you can see there's a large area of cavitation caused by the necrosis. Here we see betadine being injected into the wound to kill any infective organisms that are there, but of course it can't reach all parts of the wound because the patient has osteomyelitis. Unfortunately, shortly after these shots were taken, it was necessary to amputate this infected toe in order to remove the area of osteomyelitis. Here we can see the large area of necrotic tissue by the amount of packing that it's able to put into this toe. This shows the amount of tissue which has been destroyed by the infection. And because this patient had type 2 diabetes mellitus, the normal inflammatory changes and the normal inflammatory defense mechanisms worked less effectively than in a non-diabetic patient. Here we see a very nice dressing being applied, but this was very much a palliative measure prior to the amputation, which was shortly subsequently required.